So I'm very briefly going to tell you about our own experience and how we started the program, and if you like to start a program, how to approach it a little bit. So right now we're the only hospital in the Netherlands performing these kind of treatments. So it's a 60 million people population and one hospital serving these patients. And we started in 2005, and since 5 years we have really a dedicated bronchoscopic lung volume reduction program running, and we really stay focused on this field because it's really a huge amount of patients, and you really need to build up your experience and your knowledge in the field. So in 2012 we got over 300 referrals from colleagues all over the country with their patients being referred to us. And we discuss these patients in our weekly multidisciplinary team, discussing let's say around 10 patients every week. It's like you discuss your lung cancer patients also every week. And in 2012, just to give you an example, we performed around 75 procedures for these patients. So 75 bronchoscopic lung volume reduction procedures, which is more than the entire lung transplant and surgical program in the country together. So there's a big need, and you have to be skilled in some things. You have to know what COPD is all about and what these patients should behave like and how their optimal medical treatment is. And there are a lot of psychological factors also that are at stake. Patients feel dyspneic, and one patient copes very well and the other one does really not. So be aware of those things. And also be skilled in what you're doing. Our Jean showed that proper treatment of these patients is really crucial. And the more you do, the better you get. And also, make sure that if you start, you're really a top referral center for these things. So if you can make sure you work excellent, and if you're high volume, you get better and better. You get more referrals, you build up your experience, and the most important thing is try to adapt to more treatment options. So right now there's the valve treatment therapy is getting really close to routine clinical care, but there are more new things coming up, and really try to get involved in that field because it drives referrals, it drives your experience. And if you're able to really hook up to a lung volume reduction surgery program also, it really builds up experience even more. And it's really a multidisciplinary approach, so we can't do it by ourselves. So you need your rehab, you need your thoracic surgery, you need the anesthesiology. Lung transplant program is very nice if you have it, or if you can collaborate with a big program, because we also screen our waiting list and we bridge them for a longer time on the waiting list, or even treat patients off the waiting list, because up to a few years ago we were not aware that these patients could be helped by these techniques. And you also should work closely together with your diagnostic tools to make sure, as Arshang elegantly pointed out, that these patients are the ones we should treat. So right now we have kind of a treatment algorithm developed which we use in Groningen, where we identified Arshang's approach of emphysema, and then either by emphysema phenotype we decide what to do. So for a heterogeneous population, the first question is the fissure complete by measuring collateral flow? And if there is no collateral flow, there is no reason not to put in those endobronchial valves. You have a high chance of big success. But if you have collateral flow, then you're stuck with more experimental options which might be less effective. And then we aim for tissue destruction using eyeballing emphysema scores as possible. You can also use more advanced commercial CT software to do that. And if there is destruction below 75%, we treat these patients with lung volume reduction coils. And if there's virtually no lung tissue there, you can even go for more experimental options by biological therapeutic options, or just do nothing. For the homogeneous group, it's a little bit more difficult right now, because as I showed you, the EASE trials, so the transbronchial stents, they only work for a few days, so that's not good. And right now, post hoc data shows that both the valves might work and the coils might work, but prospective data will still have to show that it works. So the homogeneous group is still at stake at this moment. But we never forget about you guys, so surgery is always important. So especially for the heterogeneous group, which has a high destruction rate and has no really valid bronchoscopic option, these patients are probably also almost very good candidates if fit enough for lung volume reduction surgery. And if therapies fail, it's always a good escape. So you can first put in valves, and if valves don't work or give complications, but the patient is a good candidate also for the surgical approach, convert it to the surgical procedure. And With the valves we aim at anatomical volume reduction, so you can also make a surgical anatomical resection. So if we treat the left upper lobe, we were proven that the total atelectasis was good and the patient responded meaningful, but you might end up with some complications or loss of efficacy. You might end up with performing a lobectomy of the left upper lobe. And the other thing is, if things really won't work the way you like it to will and the patient is still fulfilling all criteria, also lung transplant in the end might work. So just one small case. 46-year-old male, severe dyspnea. This patient participated in the Chartis study where we validated the Chartis system, low FEV1, and as you can see over here, massive emphysema, left lower lobe, there's a little bit compressed tissue left upper, and also the right lung doesn't look very good. Over here you see his CT scan in coronal view, where you see that there's virtually, no tissue here. Also right upper lobe very diseased. So this is not a good surgical candidate, but this is possibly a very good candidate for these kind of therapies. So what we did under conscious sedation, and this is the entire left main bronchus, upper lobe, lower lobe, and we performed the Chartis treatment of the left lower lobe. So you see the expiratory flow vanishing, so there's no collateral flow, and then we put in valves in his left lower lobe, and after that you see a massive volume reduction of the left lung. And if you see before and after summer of 2 years ago, you see what the difference is in FEV1, almost doubling like Arshang also showed, and also a 6-minute walk test going from 200 to 400 meters. So these patients really feel better. And up to a few years ago, you weren't aware that these treatments might exist, and if you saw a CT scan like that, you said, well, we can't do anything anymore. But right now, every clinic has a number of these patients out there who can't do anything at all, and you can be life-changing by applying these techniques. So, and also we're pretty wise. So if we have a CT scan like this, pretty well preserved lung tissue, big bulla, more periphery originated, we ask the surgeon. So over here you can see this bulla just by mini thoracotomy, and you give some pressure, ask the anesthesiologist to make this nice picture, to get a little bit air in there, and you see how a big bulla behaves. And then you can also understand why this patient really suffers. So they did a good job there. So what's important? Team effort, patient selection has been discussed, and try to adapt to multimodalities. And training experience is really crucial to drive your own skills, your patients, and also your outcome. And in the end it all comes down on logistics. So work together with a good team, a solid team, and then you really are successful. Thanks.